Studying abroad is often described as a life-changing opportunity, but from a psychiatric perspective, it is also one of the highest risk life transitions for young adults. Not because students are weak, but because the brain is being pushed beyond its adaptive capacity. Loneliness is not just an emotion, it's a biological stressor. When a student moves abroad, the brain loses familiar social cues, language, facial expressions, tones, routines, and even food. These are not small comforts, they are regulatory signals for the nervous system. Social connection regulates cortisol levels, sleep-wake cycles, emotional stability, and threat perception. When these connections are suddenly removed, the brain interprets it as a social threat. Cortisol remains elevated, the amygdala becomes hyperreactive, the prefrontal cortex, responsible for your judgment, emotional regulation, and your concentration, starts functioning less efficiently. Clinically, this appears as persistent anxiety, overthinking, emotional numbness, reduced concentration, and sleep disturbances. This is why loneliness abroad feels painful, not just emotionally uncomfortable. Cultural transition places a constant cognitive load on the brain. Every interaction requires effort: how to speak, how to respond, what is appropriate, what is expected. This ongoing vigilance leads to mental fatigue. Psychiatrically, it contributes to imposter syndrome, self-doubt, social withdrawal, and performance anxiety. Over time, the brain begins internalizing the stress. I must be the problem. This is a known pathway towards depressive cognition. Sleep disruption is one of the earliest biological markers of psychiatric illness. Jet lag, academic schedules, loneliness, and stress disturb the circadian rhythms. Once sleep is impaired, emotional regulation worsens, anxiety intensifies, mood becomes unstable. In psychiatry, sleep disturbance is often the first symptom and not a side effect. Ignoring it allows the illness to progress. Many students turn to alcohol or substances abroad, not for pleasure, but for regulation. To fall asleep, to reduce anxiety, feel socially connected, numb emotional pain. Biologically, substances reduce anxiety initially by depressing the nervous system, but over time, they disrupt your sleep patterns, increase your baseline anxiety, worsen your mood instability, and lower stress tolerance. Clinically, we see panic attacks, depressive episodes, emotional blunting, and dependence patterns. Substances do not cause the illness, but it accelerates its course. Late adolescence and early adulthood is when many psychiatric disorders naturally emerge. Add on to that the chronic stress, loneliness, sleep deprivation, substance use, lack of early support, and the brain crosses its threshold. This is why psychiatrists frequently see first episode anxiety, depression, panic attacks, and mood instabilities during overseas education. Many students delay help because of guilt. They feel the pressure to justify financial sacrifice. They fear disappointing their families. So symptoms worsen quietly. By the time help is sought, the illness is more severe and harder to treat. A psychiatric consultation does not automatically mean medications. Often it means therapy, early identification of vulnerability, sleep stabilization, stress modulation, psychoeducation, and preventive planning. Early intervention reduces your illness severity, improves academic functioning, prevents dropouts, and protects your long-term mental health. Struggling abroad is not a failure of character. It's a predictable neurobiological response to prolonged stress and isolation. Preparing the mind is as important as preparing your documents. Mental health screening before or during overseas studies is not an overreaction. It is responsible, preventive care.